Me.
Save you time. Yeah.
Mine's off. All right, good evening and welcome everybody. We will call this West Kootenay Boundary Regional Hospital District meeting of March 25th to order. We have two additions to the agenda. So the first one is item 5.1, which will be the appointment of Christine Linton as alternate director for area. Yeah. So that will take here as 5.1. And then 8.6, Director McLaren Coe will speak about AKBLG and Minister Osborne being in attendance. I have a motion to adopt the agenda as amended by Director Worley, seconded by Director Jackman. Any discussion? All those in favor? Anyone opposed? It's carried. Sorry, I'm going to back up a bit. I missed the land acknowledgement. I was so focused on my notes in red. So we acknowledge and respect the Indigenous peoples within whose traditional lands we are meeting today. So now I'll go back to the agenda. So the receipt of the minutes, if there are no errors or omissions, the motion is that the January 28th West Kootenay Boundary Regional Hospital District meeting minutes be adopted.
Moved
by Director McGregor and seconded by Director Martin. Any discussion? Well, I'll just call for opposed.
Yeah, that's easier.
All right, so those pass. And we have a delegation this evening from Dr. Carly Sylvester. Oh, sorry, 5.1. So at 5.1, the recommendation is that Christine Linton be appointed as alternate director for the West Kootenay Boundary Regional Hospital District for 2026, representing Regional District of Kootenay Boundary Area D. Have a mover for that? By Director Jackman, seconded by Director McGregor. Any discussion? All those in any opposed? Motion carries. Now we'll go to our delegation. So Dr. Carly Sylvester, who is in the corner here behind me, and she will be sharing her screen, and Dr. Stephen Sylvester, who is online. Welcome to the meeting. So you will have 10 minutes to make your presentation, and then there will be about 5 minutes for questions, unless it by mutual agreement that the time is extended. So welcome and
okay to start?
yeah, perfect. You're good.
Good evening and thank you, Chair Hewitt and members of the board for the opportunity to present this evening. My name is Carly Sylvester and I'm joined virtually by my husband, Stephen Sylvester. We are here to present the strategic case for a Tier 2 medical hub at Big White Mountain, a project that we believe is essential for the safety and health. We speak to you today both as clinicians and part-time residents of Big White Mountain. I'm a practicing ophthalmologist and Stephen is the chief of orthopedics at Kootenay General Hospital. We moved to the Okanagan from Toronto in 2016, but are transitioning to a more permanent position on the mountain as our 3 sons will be attending Big White Community School in the fall. Our advocacy for this hub is rooted in what we see daily, a significant gap in clinical and regional clinical infrastructure that affects both residents and visitors alike. It is a common misconception that Big White is a resort. In fact, it is a major population center in our DKB. Big White's permanent residency has grown by almost 300% since 16. And for 6 months of the year, the average overnight population exceeds that of Trail and Grand Forks combined. At peak times, Big White sees a city-scale volume of 20,000 people a day. Yet, unlike any other city of this size of the province,
I'll interrupt you for a moment. Apparently, they're having trouble hearing you online. So if you want to come up to the table here so
No, I
you're
can
closer. Oh, okay.
Can you hear me now?
No, it needs to be picked up by our system.
Oh.
Otherwise we get that reverberation.
This is all the sound system.
Maybe the corner of the front.
Right.
I think at the table, I think at the table will be fine, because I can hear you fine.
Right.
Can you hear me?
Is that better?
I can speak louder.
Yeah,
Try.
that's better. Thank you.
Big voice. So I'll start that over. So at peak times, Big White sees a city scale volume of 20,000 people a day. Yet, and unlike any other city of this size in the province, Big White operates with zero public health infrastructure. There is a stark disparity between Big White's tax contributions and healthcare funding. Big White is an economic engine that generates 22% of regional tax revenue and 20% of regional hospital district contributions. Yet Big White receives zero capital allocation for local healthcare infrastructure. This lack of infrastructure has a measurable human cost. 2021 data published by Interior Health shows that West Boundary, or LHA 127, has the oldest population and the shortest life expectancy in the entire health authority. The median age at death in this region is just 73, which is 6 years younger than the BC average, and the mortality risk is 20% higher than the provincial baseline. These findings reflect the geographic barriers or travel burden faced by rural residents in this region. Both rural health benchmarks and trauma best practices identify a 1-hour distance to the nearest hospital as the critical metric for patient outcomes and infrastructure planning. Although Kelowna General Hospital is 58 minutes from Big White in perfect conditions, the reality is much different. The average wait time for an ambulance at Big White this year in 2026 is 52.3 minutes. This means that the effective distance to life-saving care is 110 minutes, which is nearly double evidence-based guidelines. For rural residents in West Boundary, this distance equates to greater financial burden, delayed diagnoses with worse prognoses, higher rates of preventable hospitalizations, and shorter life expectancies. For trauma and cardiac patients, this distance is associated with significantly higher morbidity and mortality. Big White's dependency on EMS is absolute because there is no local imaging or stabilization available. As such, Big White has some of the highest EMS call volumes per capita in the province. In fact, it is 15th on the list of the top 150 communities with the busiest call volumes per capita in BC. And yet, Big White is the only community on this list without a permanent 24/7 EMS station, and it is one of 3 communities located more than an hour from the closest hospital. When an ambulance leaves the mountain to take a patient to KGH, it leaves behind an extremely vulnerable population with a higher risk profile than most other communities. The higher risk profile at Big White Mountain arises from the high energy trauma associated with skiing, snowboarding, and mountain biking, alongside cardiac events in an aging resident population. This season, Ski Patrol responded to an average of 12 calls per day, and in 2025, the fire department attended 87 severe medical calls for which 911 had to be dispatched. The medical load on first responders is significant, and so is the downstream impact on the region. Data collected by Ski Patrol over 103 ski days this season revealed that almost 500 people required immediate transfer to KGH emergency department, and 1 out of every 3 of these patients needed an ambulance to get there. While the utilization of these resources is necessary in some cases, for many it is simply to access basic diagnostics like X-ray. The demand on KGH resources by West Boundary residents is demonstrated here in the 2021 data published by Interior Health. The standard tertiary referral rate to KGH from local health areas within Okanagan, RDKB, and RDCK is around 12%. In contrast, West Boundary utilization of KGH is 150% higher than the regional average, which reflects the large volume of non-tertiary primary care flowing primarily from Big White and Beaverdale. But the systemic strain doesn't end there. A lack of local primary care for residents of West Boundary may contribute to prolonged hospitalization after acute care needs are met. In fact, patients from this region occupied acute care hospital beds almost 20 days longer than the provincial average in 2021. To illustrate how quickly our resources can be exhausted, consider the events that occurred one Monday morning on the mountain. First, a 26-year-old snowboarder dislocates his shoulder an hour after the lifts start running and is transported to KGH Emerge for imaging. Shortly after, a 58-year-old female breaks her pelvis while skiing and waits for 3 hours in the back of a fire truck without any pain control while the ambulance gets rerouted twice after leaving the mountain. Then, at 1 p.m., a call comes in for a 63-year-old male experiencing chest pain and shortness of breath while cross-country skiing. There's no ambulance on the mountain. One fire truck and crew are already tied up. And since it's a weekday, there are no ski docks available to assist the ski patrol. Luckily, this patient was able to get a ride from a friend to KGH, where he underwent treatment for a non-STEMI. This clinical near miss highlights the need for deliberate healthcare planning rather than relying on luck to achieve positive health outcomes for our population. The cascade of events observed that Monday were the direct result of a deficit in local diagnostic and stabilization capacity. Utilizing an ambulance as a shuttle for a minor injury simply to access imaging and for a routine shoulder reduction is a profound misallocation of regional resources. This practice strips the mountain of essential emergency coverage and shifts the burden of care to an overwhelmed KGH emergency department. Instead, we propose a local Tier 2 medical hub at Big White to reduce the downstream burden and systemic inefficiencies of the current system. By providing on-site triage and imaging, we can stabilize high acuity patients for safe transfer and treat low acuity injuries locally. Not only does this contribute to better patient outcomes, it mathematically preserves EMS unit hours and directly unburdens the tertiary resources at Kootenay General Hospital. Our vision is a hub built on 4 pillars: trauma stabilization to protect EMS and KGH capacity, primary care to establish a medical home for 1,000 plus permanent residents, specialist outreach to reduce the travel burden for residents from RDKB and beyond, and finally, clinical teaching as a rural training site for the Southern Medical Program aid recruitment. This proposal is strongly supported by the community. Big White Ski Resort Limited is committed to collaborating with the board of provincial partners to make this a reality. They recognize that on-site stabilization is the only way to ensure the long-term safety of the community and the efficiency of regional emergency services. We have the clinical leadership and a highly engaged community. What we now need is a formal planning partner. We are respectfully requesting that the West Kootenay Boundary Regional Hospital District authorize funding for the medical feasibility study. This is the essential first step to accurately assess the site and clinical requirements needed to bring West Boundary in line with provincial safety standards. Thank you very much for your time and consideration. Again, we look forward to answering any questions you have.
You did a good presentation.
Thank you. So we've got a few questions for you. I've got Director Jackman in the room.
Great, thanks very much through the chair. When I read this in the agenda, I found this highly illuminating. The numbers are surprising to me. I was on the crew that first paved that road in 78 or 79 or something. I haven't been up to Big White much. In the past, we've done things like we funded 100% of the initial study to move forward with the Nakusp emergency room because the health authority just didn't have any interest or priority to look at it. So I can see a board like this funding something like this when it looks as though it's a pretty big gap. But the question is, did you go to the health authority for feasibility funding? And why didn't they just say, hey, here's a gap, yeah, we should just do this?
Interior Health.
Yes.
I've spoken, Stephen and I had a meeting last week.
Yes.
As well. I think right now we're looking at next steps in terms of how this could work. doctors, we don't do a lot of this side of medicine. So we're just figuring this all out as we go. And part of the feasibility study, I think, will be trying to find partners who would support this.
So this is the path recommended by Interior Health, start here.
That is the recommendation. I don't think we're on the radar yet with Interior Health.
Trying to get there.
Trying to get there.
Could we take down your presentation as
Oh,
well, so
yes,
that
of course.
you can see you. All right, and then we have a question from Director Lockwood online.
Thank you. And if I start coughing, I apologize. That's why I'm not there. I'm not very well today. My question is that if the feasibility study shows that it is something that's going to be funded there, as a municipality in Salmo, we actually own our medical clinic, and we paid for it and built it of $800,000, thank God, before COVID. And I'm just wondering, and how we fund stuff in it is we have a thrift store that raises a ton of money. Is there that kind of thing that's being looked at if this goes forward? Because as much as it's wonderful to have, and I get, because my son is a skier there, I get that we want services there, but it's a much broader picture of not just building it, but how is it going to be funded going in the future? So I'm just wondering, has that been thought about? And I know that you're doctors and you guys don't do these kind of things, and I appreciate that putting that forward. But I do think that that is something that needs to be considered. And it's very interesting that IHA told you to come here first instead of them doing a feasibility study. So I don't really have a question, I just have a comment.
Go to Director Gibbs.
Thank you, Chair Hewitt. Currently up at Big White, Sharon Gibbs, Area Director for West Boundary. The Big White Community Development Association has been lobbying hard for a community space, and we're right in the middle of an official community plan as well. So there is some funds put away right now towards that goal. But this is a good time to bring this forward as we're in the planning stage of all of this. So thanks for your question, Diana.
All right, so I'm gonna go to Lannon next because it's probably directly in response to what's been said, and then I'll go to you, Frank.
Thank you and good evening, and through the chair. Just for clarity, my perspective is that the Health Authority is not advised that this, for the first step, be to come to the Regional Hospital District. As noted, my one and only meeting was last week, and this was set to be on the agenda before that meeting. There was just a preliminary conversation to understand the context behind the want, recognizing that establishing new services in a community is one that doesn't come with a guidebook and involves consultation with multiple groups, including this group. So I think it is advantageous to have the conversation, but just wanted to make sure that there was clarity about what steps have occurred from my perspective. Thank you.
Thank you, Lannon. Okay, so Frank, we'll go to you. Director Marino, sorry.
Thank you, Chair. And thank you, Dr. Sylvester and Dr. Sylvester for being here. I mean, your report is like said before, it's very enlightening about what happens there and how much healthcare resources are actually used. And I think this is the next step for a community like Big White that's growing and expanding. Now, I see that you had a letter of support from Big White Resort, which is fine. But one of the biggest benefactors in any kind of new facility up there will be the resort itself. So when I'm looking at this, I don't know exactly what the steps would be working with, because IH will have to be involved, obviously. But have you asked Big White to support part of the feasibility study in a shared costs with the regional hospital board and maybe IH? Because I think they should step up to the table too.
So we have not,
Yes.
we have not directly approached them for
Okay.
funding for the feasibility study.
And I'm wondering if that's something maybe the regional hospital board would do, to ask them to be part of this in a more substantial way.
I would say that's not our job to
Yes, exactly.
intervene in something like that. Director Page.
So
Actually,
it is-
sorry, I had someone else in front of you, Director McGregor.
Go ahead if that directly,
No.
okay.
So did you have a supplemental, Director Marino?
Well, and then is it our job to do the feasibility study on our own? I don't know. I mean, I've never been involved in this before.
Well, we're not making that determination tonight. We won't be dealing with the request at this meeting. It would go to the next meeting for discussion and consideration. We just hear the delegation tonight and have the ability to ask questions. I have Director McGregor next. and
Thank you
then
through the
Director
chair. Excellent presentation. Thank you very much. And I am aware of what Big White brings to the table, big time. And it's important to our regional district. I will say that to begin with. I would think that Kelowna would be really supportive of this. Because at the end of the day, those patients are trying to get to that hospital. And I've been at that hospital when those emergency patients have been marched right out the door. There's been so many of them lined up. So I would suggest you might want to have a conversation with Kelowna as well. I don't know who in Kelowna because I don't know what that looks like, but Interior Health would know that. And I think you should ask them for that information. I think also that if you put this out to the whole of Big White and you get a whole pile of letters and you get a bunch of people that are saying it is time for us, then I think you'll get some more. But it's going to take that because literally, I will say that this room alone, when we ask for things here, even individually, and we sit here, and we've been sitting here, some of us for a long time, rarely do we get that often because it's already in a package. So it's a difficult road to go, but I think that this can be done, quite frankly. And I believe that it's going to take a lot of work on your part, Sharon's part, if I can. And I think it's going to involve other hospital areas who see the need for that kind of thing. Even in Grand Forks, I would think that most of us in the area would also support that because we're looking after patients, all of us, right? So thanks for your presentation. I think it's important.
We've got, I have two more questions, and then I think I'm gonna have to cut it off because we're over time. So Director Page.
Thanks. Reiterate the points. Great presentation. Really enjoyed getting some of that knowledge about some of the needs that you guys are seeing. My question was for Landon, and it's particularly around the comment that there's no playbook for this. I'm curious, especially at this board, how we take a look at where some of these evolving gaps show up in care and facilities and resources, and how that integrates with the board decisions that we see on the map, because community and demographics are continually shifting, and this is one highlight, but it certainly exists within a continuum. So I'm curious how we can incorporate maybe a more holistic view over time that we can identify these gaps and not necessarily be dealing with it on an ad hoc basis, but that there is a bit more of a playbook and decision-making process that we engage in to both add new services and at times reduce services.
Through the chair, the population health planning work occurs on a cycle. As was referenced, there is population health data that Interior Health publishes on a cadence of about 5 years that looks at a number of factors that include, among other things, the size of the population, the age of the population, general demographics of that population, projections around growth, and general health and well-being considerations, chronic disease, smoking, alcohol utilization, a number of public health determinants of health. That is used organizationally to help us understand where we might see demand. And while we attempt to apply scientific rigor to the process, it helps us guide decisions with respect to investment, as we've seen investment in communities across the health authority in both hospital beds at certain sites, as well as long-term care development, as well as the demands that we see. That's often the most common driver in the system with respect to changes that we see. Where is the increase in demand coming from? We work to understand what is driving it specifically. Is it from a particular area, a particular demographic, and then work to address those demands specifically. I have had conversations with my colleague Lindsay Taberner at Kelowna General Hospital. As I understand, and more digging should be done to make sure that we have clarity around this, but as I understand, the demand coming from Big White specifically hasn't been identified as a significant driver of capacity in the emergency department. It's not to say that there aren't. Clearly there are individuals who utilize the hospital for services. I'm just not sure that it is the number one concern for them that requires a path or an approach to address. So we use the data to develop the plan, and then the plan goes into our process. And that process, of course, is an interplay between the health authority and government to determine where we would be able to invest resources. I have been with Interior Health for 10 years, and I am not aware of a new acute care type facility. We have invested in urgent primary care facilities and long-term care, brand new in communities, but maybe not something quite of this magnitude. So my comment about there not being a playbook is with respect to something specific to this.
Thank you,
Thank
Landon. Director Cunningham.
Yes, thank you. It was Selma in Area G. I'm the representative from Area G when we did the thing. We were lucky though, because we had an old clinic and it was owned by the doctors. And when the doctors felt they didn't have enough business, they shut down the old clinic and left town. It's left us with no medical services in town whatsoever. We got together and we basically went out, found a doctor from Saskatchewan, and then we leased the clinic from the doctors, the old clinic from the doctors. And then we contacted Interior Health and the province. After it was quite a very, very long thing. The big thing was Salmo donated the land, and Salmo donated the land, and the new facility was designed with the help of Interior Health and by looking at other facilities of the same type. And this was still only a clinic. It is not it is nothing along the scale that's being proposed here. And we were able to once we both Salmo and myself agreed to give $10,000 a year towards the funding the loan for the property, we were able to get the property, and then Interior Health helped with the rest to bring it up to the total of $800,000, which was 15, 20 years ago now. So you can imagine what such a facility. And then in the end, the town ended up owning the old one and turning it into the community hall. The town hall, which is so they got, because before that they were in the fire hall. So everybody gained. However, it was a long process and it was difficult. And But once we were on the road and had the backing of the province, then it was easier. They helped us, we didn't have to go out and hunt doctors down or anything like that. They helped with that and the ones and they assigned certain doctors. And in Selmo, at the present time, if you don't have a doctor, move to Selmo because they have to, because they will service you. They can become your doctor.
Director Cunningham, did you have a question for our delegation?
No, I just wanted to point out that they do have, a long road to hoe, and I wish you the best. I mean, but yeah, the big thing is I think you need the help of the province and start beating on your MLA.
All right. I said I was gonna end with Director Cunningham, but I'll take a question from Acting Chair Baker. You got
There we go. I'm demiked now. Thank you, Madam Chair. From what I've understand from what Landon and DeBest has said, we are better to take the mountain to Kelowna than to try to get Kelowna to come to the mountain. Anyway, I jest, but I just want to express my appreciation for the presentation. I join with my other directors on the boundary, those that, we're in a situation where we've just, as a boundary area, set up a clinic in Grand Forks so we can guarantee our patients have doctors, or our patients have doctors if they wish one. And, knowing Big White well, I agree with Director Morano. I think that Michael J. Could cut that purse strings a little bit and contribute here. But I think this is something that needs to be looked at seriously, not with all the political buzzes that go along with it. But I think that the presentation was quite glaring, that there's a need here for something. And I certainly support that and support our area director Gibbs as well. So thank you for your time, Madam Chair.
So Landon, I'll let you respond and then we've got to move on to our next item.
Thank you, Chair. I promise to be very brief. And my comment is, I too have appreciated the opportunity, one, for the conversation last week and the opportunity to see the presentation. And following this, I will continue to work with Dr. Sylvester to continue the conversation and understand the data and make sure that we are on a path. That's all. Thank you very much, Chair.
Thank you. Well, thank you very much for joining us and take to the phone.
To come and that's a dog.
Right. And we have our delegations from Interior Health. We've got both Matt Wilkie and Landon DeBest on. We've got an update on mental health and substance use.
Thank you, and through the chair, tonight's presentation from myself is both a response to a question that was posed at our last RHD meeting with respect to Nelson services for MHSU, as well as a couple of other points that I wish to bring to the attention of the board. Next slide, please. Noting that we already conducted a land acknowledgement, I will just state that I'm calling tonight from the traditional, ancestral, and unceded territories of the Coast Salish people. Next slide, please. And as noted, Matt and I are here. Matt is also on the call, joining remotely. Next slide, please. And next slide, please. Okay, here we are into the meat of the presentation. You will also find in the package, again, in response to the questions about mental health services in Nelson, partly due to the impact of the flood back in December 2025, which I'll speak to in more detail in another slide. And also just to provide some information in general about the services that are available. The intent tonight is to provide a broad overview, knowing that the specifics are in the package for members to review. Virtually all of our mental health services as of today are located in the downtown mental health substance use building located on Vernon Street in downtown Nelson. This was already in flight prior to the flood in December. And we were able to relocate. There was fortunately some flexibility that allowed us to relocate some services from Nelson Fairview Gardens into the downtown Vernon space. And all of our services are now, virtually all of our services are being offered from this location. Next slide, please. So you'll see on this slide, and the photo is inside the building itself in the client waiting room. The list there covers the variety of services that are located in the downtown area. And we were intentional about identifying those services that needed to be accessed by people who are challenged with transportation and would have difficulty accessing services at the Nelson Health Campus just because of its proximity to the downtown area. So a good proportion of our programs related to substance use and those with complex mental health disorders are based out of the Vernon Street space. As well, we provide our opioid agonist treatment, or OAT treatment, as well as services through nurse practitioner and physician for primary care for those who have really complex both mental health as well as complex medical issues that need to be supported in a what I would describe as a less traditional GP model or family doctor model. That's the information that I wish to provide with respect to MHSU services in Nelson, and I will go on to the next section, which is to talk about the impacts and updates with respect to the floods. And so we'll go to the next slide.
Well, Lannon, we actually have one question related.
Oh, certainly.
Director Papa.
Yeah, that through the chair to Lannon is glad to hear that those services are available. But the issue that's been brought up to me is most of the time when somebody has some mental issues, they end up in emergency in Nelson. And emergency treatment is give them a couple of pills and send them home. And what my concern is, because we've got all those facilities, there is no follow-up with the person that has mental issues. So can you maybe explain how it can be followed up after emergency and they're sent home?
Yes, I can. So there are a number of ways in which clients who attend the emergency department can receive follow-up. Depending on the presentation, and it's challenging to speak in generalities, knowing that care, as often as we can, is tailored to the needs of the individual themselves. However, we have the ability to refer into services straight out of the emergency department. So when somebody presents to the emergency department with a mental health crisis, I'll use this as an example, it is likely, not a guarantee, but it's likely that they are already known to mental health services in the community. And the emergency department clinicians will connect with the community mental health team and let them know that one of their clients was seen in the emergency department and does require support. Depending on the time of the day that that person has attended the emergency department and is being discharged, that might include a very warm handoff where staff would come to the emergency department and link in with that individual before leaving. And sometimes that involves the individual being discharged with a planned follow-up by their community clinicians the next day or as soon as the team is able to reach out. The reality is, despite every effort to make sure that somebody is connected, it does still require the individual, the client themselves, to engage in those services. And there are times when individuals do not, and they have the ability to make that decision. They are capable, and have the right to choose whether or not they want to participate in services. There is only the very, very, very small subset of the population who is cared for under the conditions of the Mental Health Act or the language of the Mental Health Act, where they may not have those same rights as the majority of the population. So short answer is yes, services are there. Without specifics, it's hard for me to say what may have happened in the situations that you're aware of. However, we do have a mechanism to make sure there's continuity of care.
Supplemental, if I may. Thank you for your response. You know, and you are correct in some instances where the person is capable to understand that they need a follow-up, there is follow-up available. The cases that I'm talking about is when you send a person home from emergency with no real follow-up other than going to their family doctor, and some of them don't even have a family doctor. So what I'd like to see happen is from emergency through our mental health, somebody to follow up on that patient that didn't have the capability of making that decision to go there.
I would be happy to have a more detailed conversation with you just to make sure I can answer your question fully. And maybe we can, if you have examples, I can do some follow-up just to make sure that we're doing our part and ensuring that follow-up is being put in place for those that have been assessed as requiring that.
Thank you.
That's all the questions that I see at this point, so go ahead with your presentation.
Thank you. And through the chair, I'll pause after each of the sections of the presentation. There are just two more slides of information, but I'll pause after each one. And so the next slide is about the Nelson Health Campus flood that occurred on the Community Services Building, which is the building that you see in the front of the picture. It unfortunately, there was a burst pipe on the top floor of the building, and a flood occurred on the 30th of December. It was towards the end of the day. There were no client or staff impacts with respect to safety, and we were able to evacuate the building calmly and in a timely manner as needed. As it is an outpatient service, there were no concerns long term about needing to relocate, say, a resident out of the long-term care side of the building. Very quickly, planning went into effect, and we identified locations for all of our programs to continue to operate, with programs operating out of the Nelson Fairview Gardens component, the long-term care side, which had space. As I said, mental health services moved to the Vernon Street location. Some of our services moved to an increased virtual option, with some services being offered also out of Castlegar as well. And so we continue to have programs displaced. The building has not reopened, and there is still, it will still be some months before we are able to fully return and reoccupy the space. But we have been able to move the adult day program already. It's back into its previous work space. As well, we've been able to reoccupy the southwest corner of the first floor, which has allowed us to have our nurse practitioners and some of our older adults mental health services operate out of that space. And also this week, we were able to move the public health program back to its space on the second floor of the Community Services Building, as well as the Early Childhood Development and Children Assessment Network, also moving into their space on the second floor of the Community Services Building. The space that we've been able to identify is quite accessible to the public, and fortunately, was not impacted by the flood itself. We, because of the moves of services, at the time of December 30th, Nelson Fairview Gardens was opened at 30 of 75 beds at that point. 45 of 75 beds were occupied at about that time. Now that we have moved some services back this week, we will be able to resume admissions into long-term care, and we'll be increasing the occupancy of Nelson Fairview Gardens to 60 beds. Due to the displacement of the home health team, which is normally located on the 3rd floor of the community services building, they will continue to operate out of the 1st floor of Nelson Fairview Gardens, which has no long-term care residents in it. It has been empty as we slowly admitted residents into the space. They will need to remain there because the option of returning to their previous location on Gordon Road is not feasible. And the time necessary to renovate space for home health to operate out of another location is just, it's not feasible. It will take too long, and will create unnecessary movement and disruptions to services. So they will remain in place. And like I say, Nelson Fairview Gardens will open to 60 beds in the coming month. There may be some questions about why we hadn't occupied to 100%. We had started admitting into long-term care at the beginning of October, and that process does take time. It is quite an extensive admission process for any new long-term care resident, and so there was always a requirement to pace the work very carefully to ensure the safety of new residents, safety of staff. In addition to that, there were still some small modifications required to the space to make it 100% usable. And some of those were required by the health authority, and some of those were required by the licensing body for long-term care. And we didn't have permission to occupy some space until closer to November, for example. So we'll continue and look forward to work to get all of our services back to where they were designed to function out of. And I'll pause there to take any questions, Chair.
Director Papa.
Thank you, Chair, and I hate to monopolize with questions here. But that was a facility, I believe, that was supposed to have 85 long-term care beds. So how many beds are there finally going to be available?
It's built for 75 beds, and it will be open to 75 beds. We won't be able to fully occupy the space until the remediation of the community services building is complete, at which time we can relocate the home health department back and then open the last 15 beds. So effectively now we are opening to 60 of 75 beds.
Hey, thank you.
Are there questions on this section before Landon moves on? Okay, no other questions at this point?
Okay, next slide, please. Some, I think, exceptionally great news. And I apologize, I should have made the title of this slide Kootenay Boundary Medical Staff Recruitment. Medical staff is the terminology that we use that includes both physicians and nurse practitioners. The main message to take away here is that in the last 12 months, the Kootenay Boundary has recruited 25 physicians and nurse practitioners. Compare that to the year prior, where it was 10. So significantly increased the number of new physicians and NPs coming to the community, which is having an impact on the number of folks who are being attached to services, and ultimately has really turned the tide of how we can deliver primary care in the Kootenay Boundary. This is work that I wish to give credit to my partners and colleagues at the Division of Family Practice, who in conjunction with the Health Authority invest a lot of time, effort, and money into getting talented medical professionals into our community. And these 25 new clinicians are being recruited to multiple communities. I'm sorry, I don't have for the board tonight the numbers who are going to each community, but I know that they are being distributed across the Kootenay boundary. The reason for this success is threefold. So one is real success in getting interested applicants converted to formal recruits. Upwards of 75% of applicants become recruits and land and choose to work in the Kootenays. Two, the other driver of this is the physician compensation model, which is of course directly related to physician recruitment, not nurse practitioner recruitment. But provincially, the new model of funding has supported attracting physicians from outside of this province. And thankfully, due to bullet number 1, we're doing a great job of being ahead of other communities, other areas in giving people information and supporting them to pick the Kootenays or the boundary as a location to plant their roots and work. And then finally, uncertainty across from south of the border, as well as other international locations, as well as east of this province, is driving people to British Columbia. And we are, again, experiencing the benefits of that uncertainty. And I will pause there, Chair, and I'm open to any questions.
We have a question from Director Davidoff.
Yeah, thank you, Chair. Thank you, Landon. Good news, but still not, we're still 50% short. What is the number? You said there's a 50% decrease in the Health Connect registry.
Mm-hmm.
So what is that in numbers? And then I have a supplemental after that.
So the Health Connect registry, for those who are maybe unfamiliar with it, is a system an electronic system, internet-based, that allows people to register their desire to have a GP or an NP for their primary care. These are obviously individuals who are looking for attachment in some way. It does not capture those that maybe choose not to have attachment to a GP for a variety of reasons. The number has moved from approximately 9,000 last year to about 4,000 now.
Okay, supplemental, Chair.
Let's go ahead, Director Davidoff.
So we need an additional 20 family physicians and nurse practitioners. Would that be the number that we are looking for?
Not entirely, not to address the health registry. Most panel sizes for physicians are between 1,000 and 1,500. So 3 to 4 physicians would be sufficient to address the Health Connect registry. We anticipate still that those numbers might decrease as physicians are increasing panel sizes for a variety of reasons. And so over time, we might see that number continue to drop. Second, recruitment doesn't stop. We still have physicians, nurse practitioners in our system who are approaching the end of their careers and wish to retire. So we will continue our efforts to recruit into communities to support people, moving on to the next chapter of their lives. And also, just continuing to narrow the gap to support those who we know are still looking for care.
Yeah, thank you.
Thank you. Great. Is that the end of your presentation, Landon, or is there another component to it?
That is all. Thank you, Chair.
Thank you very much. Right, so that brings us to our business arising from the minutes, and that's regarding the capital funding request for 2026-2027. we have got 13 bylaws. So I would entertain a motion to move them as a block from items 440, bylaw 440 to bylaw 453, unless somebody would like to move one for individual discussion.
So moved.
Okay, well, I had Director McGregor first
Seconded.
and then seconded by Director Popoff. Any discussion regarding moving them as a block and passing them as a block? Right? No one online. Okay, all those in favor? It's scary. So then that brings us. Okay, so that was for 3 readings, sorry. Skipped ahead. All right, so then bylaws 440 to 453 for adoption, authorizing the chair and secretary to sign. Moved by Director McGregor, seconded by Director Page. All those in favor? Sorry, did we say all right, so that motion passes as well. Oh, yeah, I think she was just voting for it. All right, so then we have. Okay, so bylaw 454, the West Kootenay Boundary Regional Hospital District Capital Expenditure Bylaw. And there's the three scenarios, which Secretary Treasurer Warren will take us through.
Sure, thank you, Chair. Through the chair, for those of you who might not have gone through a budget process before, what the habit has been in the past is creating a couple of scenarios for you to take a look at. In the past, it's really been about what's the contribution to reserve over the past number of years. It's kind of shifted because in 2024, I would believe it was, there was a rather large ask from IHA, and then that followed with another significant ask in 2025. So we had an operating surplus that was used up. So now the budget has shifted a little bit, where the suggestion is to use reserves from a budgeting standpoint to balance out the budget. And the reason for that is that although you've got about $28 million in commitments towards IHA after those bylaws were just adopted, you're not going to need $28 million in 2026. You're probably not going to need the full $28 million until 2030, the way that these projects go. So taxing for the entire amount to balance the budget doesn't make a whole lot of sense when you have reserves that are currently unallocated. So really the scenarios look at a 0%, 2%, 5% tax increase with the corresponding amount being pulled from reserves from a budgeting perspective to balance that budget.
Questions? Director Cunningham.
I'd like to move to 2%.
Pardon me?
I'd like to move to 2%.
Okay, so that one is scenario B, is it? Scenario B. So
That's
Director Cunningham has put that on the table. Is there a seconder for that motion? Director Popoff seconds that. So we'll have discussion on whether to consider scenario B. Director Jackman.
Sure, thanks. I guess the only comment I could make, and this is to the public, if any are online, plus maybe internal health. It's really tough to make any choices that make any sense without accurate cash flow projections, because that's what this is all about. But right now, and that is a later business item on this agenda, we're gonna look at borrowing again. And every time we borrow, if the cash flow projections aren't meant, it just costs the taxpayers money, because we never make as much on investment as we pay on putting out borrowing and putting out the interest payments. So to the public and interior health, without better data, better numbers, better projections, we're throwing a dart, is the way I feel personally, because we never know if our reserves are gonna be more or less than what we actually need. What I don't wanna see is that our interest rates every year will soon be 10% of our entire taxation and maybe growing. So better numbers would sure help. Because right now, it's a bit of a guess.
Director Page.
So my question is really like going into what our practice will be for next year, because that was my instinct as well, is how are we understanding our levels of reserve or whether they're healthy and they're meeting the expectation with that inflow.
Through the chair, I think that it really depends on the capital projections from IHA for larger projects. In the past, this board has usually taxed for the general ask and the global equipment grant, but then when something like the MRI comes forward for an ask of just under 14 million, there's been more of a consideration to borrow. KBRH is another example where a lot of reserves were used up for that, but still the borrowing came through at just under 10 million for that, and that's the only borrowing that the board currently has. But it's been practiced to borrow for those larger projects. Right now, we don't see that coming from IHA in at least the short term. So I would say right now, those reserves are healthy for the current environment. Unknown in terms of what might be coming 5 to 7 years from now. But for the time being, that's why the budget suggested to go forward this way with about 1.2 going towards or coming from reserves.
Supplemental?
Can we give some direction to pick up on this theme and try and flush some of those longer term pieces out in the coming year? Can we get a better sense of where we need to be in 15 years and establish, a better practice that will anticipate some of those larger capital spends? Is that work we can undertake?
Through the chair, and I might let Matt speak to this if he wants to, but I think from my perspective, we've tried the conversation with IHA around the longer term planning, and getting to that 10 to 15 year timeline hasn't really been reasonable for them to be able to put forward. We kind of worked on a 3 to 5 year at best when it comes to trying to look out as far as we can and get solid numbers that we can actually do something with and suggest to you that it makes sense to tax more and put more into reserves, and being honest about that from a numbers standpoint.
Kind of know that there's gonna be something big. Even if you don't know what it is. Anyway.
So Director David off next.
Yeah, thank you, Chair. I just have a question through the chair to our Secretary Treasurer. So if we vote in favor of this option, we're pretty much voting for a status quo budget. Is that correct?
Through the chair, yeah, roughly around or just below inflation.
Okay, thank you.
Further question? Further question? Okay. Anyone opposed? Motion carries. So now we need okay.
So through the chair, because the board has to see any bylaw that they're going to be voting on, we didn't know what that bylaw looked like until you voted on the scenario. So Christine's just preparing that. She'll email it out so you have it all with you. But essentially the bylaw would be like it is in the agenda package with the gap filled in with the appropriate number from the scenario, so you know what you're voting on.
Anyone needs to take a break, now's the time. But I'm not stopping the meeting, just if you need to back out. You just might miss the next item if you take too long.
I just like to go home.
You had a long day.
Like my home.
Yeah, I'm with you.
3 minutes.
6.
Oh, 6.
Young you.
Yeah. Yeah. Yes.
Yes. It's a big total. In 47,000.
The last 20 years.
Yeah, sure.
Yes.
Yes. That's 10% of our total taxation. That's crazy.
You don't like this.
I said, I was gonna say 85 bids.
I hit 50.
Yeah.
That's all, maybe 40.
Right,
So,
right.
The intermediate,
I don't really.
Yes. Questions?
Get oriented.
I'm a
I don't need to. He was there. Sent home.
It is sad.
And he went to street. Road eater.
Oh.
And.
I know. My bad.
Yeah. I'm sitting right on the.
Oh, please carry on. There's an opportunity you shouldn't turn down.
Yeah. Get worse.
You were there. In the board meeting.
Then the board.
All day.
Driving and sitting, I love to drive.
Yeah.
All right, everyone, you should have the bylaw in your email now. So if those have your computers with you. Yeah. Some device that you could review it on.
29 mil.
Yes. Is it older? Did you see Matt's message in the chat?
Just the one section.
Just looking at my email.
Taking it out of area E. What's the matter with you?
That's what it says.
Okay, well, so yes, we'll let you speak to that then, Matt. You can go ahead while we're waiting for people to read.
Okay, thank you, Chair, and sorry, I was trying to put my hand up, but was having issues. There was just a question about the longer term planning. So we have been having discussions with all the RHDs about having a longer outlook at our planning. So right now we do a 5-year plan, and there's been discussions and we've certainly heard a desire from all the RHDs to plan out further, 10, 20 years, even further. So we are looking at that. There are challenges with that, planning out that far in advance, but just did want to confirm that there are ongoing discussions and assessment into doing that. So we'll certainly keep the board apprised if and when we're able to do that, and acknowledge that that can help with your budgeting process. Thank you.
Thank you, Matt. Great, so so the recommendation is that the West Kootenay Boundary Regional Hospital District Capital Expenditure Bylaw 454/2026 is hereby read a first, second, and third time. By Director McGregor, by Director McLaren Cole. Any discussion? Anyone opposed? Is carried, and that the West Kootenay Boundary Regional Hospital District Capital Expenditure Bylaw 454/2026 be adopted and the chair and secretary be authorized to sign the same. Moved by Director Cunningham. By Director Worley. Anyone opposed? Is carried. So that brings us to item 7.17, which is bylaw 439. Which was referred from the March 26, 2025 meeting, and that regarding the West Kootenay Boundary Capital Expenditure and Borrowing Bylaw. So if somebody wants to move that or discussion.
Question. We don't always have a summer meeting. So question through chair to Terry is, what's our last date to do this if in fact we need the money for fall?
The chair would be your June meeting.
So we have to have a June meeting if we refer it. inclined to refer it, that we see cash flows, but I would like to hear from my colleagues.
Discussion.
I like the idea.
I do too.
So I vote referral to the June meeting.
Okay, so discussion on the propriety of referral only. All right,
Chair, if I could. So through the chair, it sounds like on the priority of referral, you'd like to have information on cash flows by that meeting.
okay. Question on the motion to refer, anyone opposed? It's carried. New business, here's a report. Well, it's not very much has happened because it's only been a couple of months. I did have the opportunity to have a meeting with Lannon just prior to our regional district board meeting. It was just last week, and just to touch base on what's happening in our community, as well as we talked briefly about what was going on at the BRD. So not at this hospital board. So not a lot. Lannon spoke to everything we had talked about. So I just appreciate the opportunity to have the interaction and have discussions with you. That's about it. And thank you again for the opportunities to serve as your chair for this year. So we will move on to the accounts payable summary. There are no questions about that. That report has been received. Questions? And then the next item is the Interior Health Authority and Regional Hospital District meetings. Recommendation is that the attendance at the annual meetings between the Interior Health Authority and Regional Hospital District chairs be approved for the chair and the secretary treasurer on an ongoing basis, and that the chair's per diem and allowances be paid in accordance with West Kootenay Boundary Regional Hospital District Bylaw 117 and subsequent amendments. Here. Okay, moved by Director McGregor. By Director Martin. Any discussion? Anyone opposed? It's carried. And then the letter of support from Director Gibbs regarding the feasibility study for the Big White Trauma Center has been received. And UBCM. Next is a discussion regarding the provincial cabinet minister meeting priority topics. Does anyone have any items that they would like? Okay, Director Popoff, go ahead.
I was gonna bring up the mental health issues, but I think, would it be worthwhile to have it, at that cabinet meeting or not? I think, Lannon addressed the issue quite well for the Nelson issue, but, I don't know if any other area within our hospital district has similar problems on mental health issues and follow-up after emergency or not.
Imagine everything.
Certainly consider it. I wonder if we should, if we have a few items that are identified, if we have an executive committee meeting to discuss them. So we'll just take general ideas at this time, and then the executive committee can flush them out. So in the interest of getting people home who've had a long day. Director Jackman? Oh, and then Director.
David Leffman, but-
Okay, all right.
So, two thoughts, maybe McLaren Co is thinking what I'm thinking. We'll have a unique opportunity to speak with Health Minister Osborne. And we may find ideas arise from there at AKBLG. And would it still be in time if we now will hold a June meeting to put in the request? It's not as rigid for UBCM. Well, but there's two sets of meetings in UBCM potentially. One is with Health Authority CEO, and the other one, of course, would be with the minister. But would the June meeting still be in time for a official delegation request? So I'd be interested in seeing how our conversation goes with all of the Kootenay and our, like Golden and other partners and bring our consolidated issues forward from
Okay,
that. That's it.
that's a good idea. Thank you. Hey, Director Davidoff.
Yeah, I just want to follow up on what Director Pop was raised. When we did the hospital tours, that's about 10 years ago, I guess. When we're going through the Castlegar District Health Center, we asked, how is mental health addressed in terms of priorities in our area? And we were told point blank, because we had a shortage of psychiatrists at the time, and it was a triage mode. So are we still operating in triage mode when it comes to mental health priorities, or do we have
A need to recruit more psychiatrists into the Kootenay boundary. That is for sure. The service is still, as you say, operating in a triage mode. I think I would say that many services do. We look at and prioritize the severity of someone's current condition and make decisions about how soon they need to be seen on a regular basis. That is just part and parcel of the assessment that occurs with any referral that our teams receive for community-based services. We have successfully recruited a new psychiatrist who's providing services virtually, but again, we are still looking for additional psychiatrists to work in the Kootenay boundary. I believe we have done well to recruit into our vacancies for the mental health and substance use teams throughout the KB. I can't say with certainty that we don't have vacancies, but we've done really well.
so
Otherwise, for nurses and other clinicians.
supplemental, Chair?
Yes, go ahead, Director Davidoff.
So it's really sad that, we did these tours over, I think, close to a dozen years ago. That's what we heard. We're still operating in triage mode. And if that's the way our cabinet wants us to continue to operate, that's not good mental health support for our most vulnerable members of our community. And that is worthy of discussion with cabinet to say, how do we move out of triage mode when it comes to supporting our most vulnerable members of our community? So that stuck with me for over a dozen years. And it's sad to hear that we're still operating in triage mode. Thank you, Chair.
Well, we have Director McLaren-Co next.
I am good, thanks, Chair. Director Jackman covered it.
Okay, Director Page.
I really like the idea of working with our partners, especially in East Kootenay, specifically around the other health services beyond surgery. It's good that we got some movement on acute, but where are we going on the rest? And I want to know from a cabinet level where we're gonna go with a replacement for Bill 12. When we think about moving out of triage and holding companies accountable for online harm and the impact it has on mental health, and that goes well beyond specific incidences, but I think there's a major contributing factor for much of the mental health issues we're struggling with what the consumer safety side of the products are for the online harm. I know that's been a bit of a sticking point for me lately, but it does make me think from an advocacy point, how are we holding the government accountable to hold those companies accountable so that we're not dealing with, as Davidoff says, the triage side after the fact, because there is certainly being harm being done. I don't know if that's a square peg in a round hole, but it feels like a place we can be pushing.
No, Stuart's made no, we'll discuss it. Were there any other items? Right, thank you all for your input. We'll work on scheduling an executive meeting between AKBLG and the June meeting. So then our next item is our next late item, and that is AKBLG. And Director McLaren Coe.
Thank you, Chair, and thanks for indulging this late item. You should have all received an email from for those of you who don't know, I'm the Vice President of AKBLG and Chair Advocacy Development Group. You should have received an email from our Executive Director, Linda Tynan, in the past few days. And in that, she describes the idea that our kind of keynote session is Minister Osborne and Interior Health CEO Sylvia Weir will be in attendance. I think it's on the Sunday morning of the convention in Trail in April. And I have the pleasure of moderating a fireside chat with those two ladies. We have about 90 minutes. We have 90 minutes set aside. I think they're going to do a short presentation, but it will largely be focused on questions from the audience, from the membership. So the call to action here is, and through the chair to Director Davidoff, I would encourage you to write in, and anybody else who has feedback, please send in your questions that you would like me or us to ask both Minister Osborne and CEO Weir. And I think, as stated earlier, it would be a good check-in for UBCM meetings for later in the year. So yeah, thank you.
Thank you, Director McLaren Coe. All right, so that brings us to public question period. Are there any members of the public online or in the room who would like to ask a question? If you're online, you can go ahead and unmute and ask your question. Give you another opportunity. If you want to unmute. All right, and then that brings us to the end of our meeting. Take a motion to adjourn at 7:21. Everybody. I'll go Director Grieve and Ferdinand was waving. So, no, just as adjourning. That was all I was doing. All right. Well, thank you everyone for joining either in person or online. Have a great night.
Thank you. Good night.